4 years ago or 3 years ago, and at that time you talked about all of that, so I rushed through that. It is a composition, steps, and you will build up a scaffold, and then you have here. She did wonderful work on the basis of that radius diluted. Skin thickness, definitely data on that. So go for it, use it. I think you can use it all over the body as well as on the face. I use it also for skin laxity all over the body, on upper arms, on legs, on knees, as Gabriela's doing it. It has an FDA approval, the normal radius with a little bit of lidocaine already since 2009, you need to know. And there are the global consensus guidelines for injecting the diluted or hyperdiluted radius. So, how do I use it on the body? There is a nice recommendation, and in my hands I love, like Tatiana, the 22 gauge cannula, 7 centimeters, because I want to cover a larger area. In my hands, I still stick to the 10 to 10 for 1.5 ml, and the dilution definitely for a stretch mark is 1 to 1, not less, because you want to have the skin production. You don't want to lose this. So, one wording please. Diluted radius is up to 1 to 1, hyperdiluted is more than 1 to 1, like 1 to 2, 1 to 3, 1 to 4. I think we should have the correct wording in the dilution. So this is my dilution. I usually use for stretch marks, and I only dilute more in areas with very thin skin, like neck, or when the upper arms are very thin in skin. So nanofractional RF, this is what I add on top of it. I want to show you this in a second. It's also a multi-talent. It's the most versatile ablative rejuvenation tool in my hands because it's colorblind. It does a lot of coagulation. You should look into the machines, what you want to achieve. In my hands, this one I can adjust. I can do more coagulation and less depth, but I can also do more depth and shorter coagulation, especially to avoid PIH. There's enough indications for that, and also combinations, and you see here nanofractional RF plus calcium hydroxyapatite is, for me, one of the best, and on upper arms, and also for cellulite, I add microfocus ultrasound. There are studies on that, on the PIH, on stretch marks with nanofractional RF, and you see a lot less PIH than with any laser. And you see an overall shrinkage, of course, because with the energy of RF, you do implement a coagulation to the side, and you shrink the stretch mark on the spot. It also does some collagen stimulation. I rushed through that, it's too much. Please look, if you do buy a machine like that you have adjustable parameters. It's not necessary, it's not nice only to, then you can only use microneedling, that's the same. This is how it looks like. These are results, and here comes my video. So in my hands for the striae with atrophic skin, I use radius diluted 1 to 1 and the Venus Viva machine. And you know, patients coming in with this atrophic, they manipulate. Like she did derma roller at home every 2 weeks, no result, or not anymore, and not enough result. So you mark your patient first, and then you decide how many syringes you need of your calcium hydroxyapatite. Remember, 10 to 10 is 1.5 ml calcium hydroxyapatite. And then, in my opinion, crucial is your nurse. Because when she does the dilution for you, she shouldn't prepare before. She should listen to you. And she should take a bigger syringe with a lure lock, not to lose any product. And in my hands, for the body, we always use 10 ml syringes. She applies a 1.5 inside, and if we do 1 to 1, so 1.5 ml saline solution on top. And then you have to go back and forth 10 times at least. And you know, then if she prepares it in advance, it will separate again, and you will have the risk of little lumps and bumps. So the dilution has to be done on the spot when you do the treatment. So here it comes. I'm nice to my patients. I always do a little blab of local anesthesia, and then I insert my 7 centimeter 22 gauge cannula. It's not a difficult procedure, but I have some rules for myself, which means I first flood the whole area, and then I go into the atrophic stretch marks in line, very superficial. So first flood the area subdermally to have an all-over collagen projection, well, possibility. And then in the second part, you take your cannula and only go into the stretch marks, okay? You see, I try to be very superficial, not to be too deep, not to lose my product. It's one-time procedure. You add on top, here you see maybe into the stretch mark a little bit, and then you add on top the radiofrequency, nanofractional radiofrequency with the needles in one session. The patients have no downtime. Of course, they should not go into the sun. It's a very quick procedure, but they do get swelling and they do get a redness. So I give them a little bit wound healing cream for the first 2 days, and then they come back after 4 weeks and we do that same all over again. I not necessarily do radius diluted at any session, but usually I'm using 3 sessions for the radius professional radiofrequency, and sometimes 2, sometimes also 3 sessions for the radius diluted. And you can see wonderful, nice results. It's shrinking and filling up. So this is in my hands at the moment, the way to go in my clinic for the stretch mark. So my conclusion, combination, always treat your patients locally first, topical. I'm a dermatologist. So tretinoin or vitamin C, all types of stretch marks, get this from myself. Then fresh stretch marks, nanofractional RF, and atrophic stretch marks, always in combination with radius diluted. Still educate your patients not to become stretch marks. Thank you so much for your attention.
Preserve instead of repair.
Thank you, Sonia.
That's the stretch marks. Thank you very much, Sonia. And we will continue actually with atopic stretch marks and a tightening of the skin on the different body areas with our lovely Gabriella again.
Yes. Gabriella Casabona. There we go.
Okay, so continuing with the things that frustrated me in my career, stretch marks used to be one of them. I would see patients that came to me, or even my own patients, that would say, yeah, after 10 months treating with CO2, Fraxel laser, carboxytherapy, mesotherapy, vitamin C injection, microneedling, all of this, yeah, I can see 30% of correction, but not really happy with the result. So I was really, really frustrated with those, because they would invest a lot of money, and either the result was not long-lasting, or couldn't see really drastic at all. So I had one patient that moved me. Really, was 18 years old, you will see her picture. She inspired me of trying something different. Because she had 18 years old, she had spears all over her body, because the doctor decided to give her pulses of corticosteroid injection for atopic dermatitis. So when she was 13, so she got stria all over her body. Beautiful girl. You will see her, so she inspired me to try something. Okay, this is her butt. So, what are the differences? What can we see that is different from the normal skin? So, stria is a scar, actually, a spontaneous scar. So you have a thinning of the epidermis, very atrophic epidermis, on top of very low quality collagen and amount of dermis. So we have a scar. And scars, when you treat depressed scars like this, you need to address more than just the skin. It's not about only the skin. It's about the epidermis. It's about the dermis, but it's not only the superficial dermis. There are some stria cases that you have full thickness compromise of the dermis. How are you supposed to treat a full thickness dermis of 2.5 millimeter thickness with a CO2? You can use scar from luminous, yes, but then you cannot be so dense because then you end up with the burning, full thickness burning. So we are a little bit limited. We were a little bit limited. So then I said, well, why not try microfocus ultrasound for that? Or why not try to treat the atrophy with something that is a little bit, that gives collagen, but also because of its color, change the color when you inject. If you see all the complications of radius, all no, but some of them are related to the discoloration, right? The yellowish look, if you inject really superficial dermal injection of radius concentrate, you will see a yellowish look. But then I thought, well, against the redness or the white, why not inject radius and change the color? So this is how I started to think about this. This is not the only procedure. Those are my cases of not radius, microfocus ultrasound, or other microneedling procedures that I used to do. So this patient, I think I did like 5 different procedures on her. And after 6 months, she was very frustrated. She said, yeah, on top of topical. So she was very frustrated, and she's young. She could have had a better result. This is another patient. This is another patient. So I'm just showing my failures. Those failures inspired me. So we have to address new collagen and elastin in all depths. So very deep in the dermis, thickening of the epidermis. So we have to use something superficial also, not only injectables or deep technology, and we have to have color restoration. Because some cases we make the gap better, the atrophy is better, but then the color is not. That was always something missing. Again, if you use all the paths you have for collagen elastin stimulation, you will be more, the efficacy is better. Again, dilution. You dilute too much, you don't have enough collagen production area. That's why I use 1-to-1 dilution. Again, I agree with Sonja. Dilute is to 1-to-1. More than 1-to-1 is hyperdilute. We need time, because biostimulation is not about immediate results. You will have something immediate because you have a chemo. But then the real biostimulation, it's not right away. You have to learn that all the inflammation and the deposit and stimulation of fibroblasts, migration of fibroblasts, takes some time. So those are biopsies that I took from my first study. 1 month, 3 months, 9 months, it takes time. So your success is determined by how much you can rely and learn from your failures. So then I had an idea. I said, well, why not use radius? And as I was studying a lot about stem cells, I said, why not use radius? Instead of using those heat technologies, why not try something cold? Without heat, like microneedling. So then I started using this in that girl. You see my first study was a retrospective study on patients, 20 patients that I used with microneedling and radius dilute all together in the same session. I would inject with the needle inside all the depthness of the stria and use the microneedling right away. And would do 2 more sessions of microneedling. This was my first protocol. So this is how I injected. You see, even for thin stria, normally I inject with needle. Normally I use a 23 gauge needle if I have deeper stria, larger stria, because Then I have big vessels right below, depending on the area, and I want to be able to aspirate the radius. So I do use 23 gauge needle. But if I have very thin stria like this, I use a 27 gauge. Then the microneedling to that endpoint. It's not just pinpoint bleeding, it's a real aggressive microneedling. 3 sessions, 1 in the same day of radius, 2 other ones a month apart. I would use deep from 2 to 2.5 millimeter. I use normally, no conflict of interest, dermapen because I do get dermabrasion and microneedling at the same time. It's very hard on a soft tissue like abdomen or legs to get penetration of the roller because you don't have a hard tissue below. You have soft, it's a soft tissue. Very hard to penetrate sometimes the roller. That's why I think those devices are better. Those are the biopsies. So if you see here, we have trichromium mason. This is just the microneedling. This is the untreated skin. You see how much thicker we got the skin to be, and the association of radius brought a lot more collagen and elastin in a very superficial manner. So there were more collagen, more elastin in the combination of both treatments. Good. This was what I could get with this protocol in some of the patients. So this is the first patient I treated. This is her inner thigh, which for me was pretty good. So this is the first session after radius, first session of microneedling, and then this is 3 months after. This is another patient after pregnancy. Other area of the same patient on the leg. This is a white stria, much better than the first patient I showed. This is an abdomen, and this is 2 years after. 2 years after this protocol. So all subjects got a very significant improvement, is statistically significant. Most subjects scored as very satisfied or satisfied. And I used the Manchester scale, as we didn't have that scale yet, I used the Manchester scale to score, and it was significantly improved. So then I published this paper. I had published before this paper showing that you can get more collagen by the combination with radius and microfocus ultrasound. Some of the cases still had some atrophy. Could you see that? So I said, should I inject again or should I boost with something else? So then I decided to try microfocus ultrasound on top of all I've done before after the treatment. And then there was subject for another protocol, which I published already also. So all patients who would have still some kind of atrophy after 3 months of the first protocol with microneedling and radius dilute, I would do Ulthera in this manner, crosshatch using the 3.0 and 1.5, which should be enough to cover the whole thickness of the dermis in the body, which is more or less from 3 to 2.5 millimeters. So this was the case, the first one that I tried, just in this round circle area, and you could see an improvement. And then I continued. This is that patient after the first protocol, and then where I put Ulthera on top. This is the first picture after first protocol, after second protocol. Another patient. So also I used the Manchester scale to score the patients, which showed significant results. Also the satisfaction crossed with the improvement were significant also, So I learned from my failures that I need to keep trying. And nowadays, what do I do if I get severe case of stria? Now that we have the scale, it will be much easier. I don't have access to the scale, but it will be much easier for us to even explain to our patients. So if I would have a severe case, what would I do nowadays, knowing all this? I would do all treatments all together in the same session. I would do microfocus ultrasound, Ulthera,